a significant jaw asymmetry with her twin sister, and some distraction and occlusion is good, and a final result. So this is one of my favorite patients because, as you'll see, he demonstrates that you can do anything you want with an ontologous reconstruction. And here he is in his wrestling outfit at his high school senior year. So you don't have to worry about anything with an autologous reconstruction. And another 3 or 4 year follow-up on this gal. When I began to get into doing the Nagata approach, sometimes I had a little too much, and Dr. Murthy was kind enough after I retired to do a revision here, and this is the end result at about 14 years of age. So the tempoparietal fascial flap is something that comes into use. Here's the first one I did. And my cartilage carving wasn't enough, but you're looking at a 30-year follow-up. So the cartilage does maintain itself, and I think that's the important thing to remember. Now this is the kind of thing you want to avoid, and if you're not good at carving, don't set out to do something until you learn how to carve. So we were able to rescue this kid using the tempoparietal fascial flap, and that's about a 3-year follow-up. So the issues are what to do with the opposite ear. And if it's sticking out, how are you going to deal with that? What do you do with hearing and hair on the ear? So these are things that come up, and you need to think about dealing with them. And they're interesting issues to discuss, especially with the insurance market. So there's a few trauma cases. This gentleman was shot with a shotgun and lost part of his scalp on the left side, and obviously had by one of my colleagues in Akron, had a flap coverage and grafting for his skull, and then presented and wanted his ear reconstructed. I'm not sure it was the best advice, but we went ahead and did that. And I have to thank Mike Parker for doing the free flap from the tempoparietal fascia on the opposite side. And he has a reasonable looking result, although he disappeared and I don't ever know what happened to him. This gal came in 1987 after the Armenian earthquake. She'd had a significant burn, lost part of her scalp, as well as the ear. And we used the tempoparietal fascial flap here. We got a reasonable reconstruction. We did a tissue expander in the scalp to get her hair down alongside the ear. And this is her final result before she went back to Armenia. This gal fell down the stairs, and there was a metal edge on the stair, and it sliced off the top of her ear. And fortunately, the auricular area had good skin, and so we carved the cartilage and inset that and then elevated it, and she has a fairly respectable result. And this gentleman was in a car accident, went through the windshield, and it removed most of his ear. And again, the retroauricular area is very nice. Skin was not traumatized, and so we didn't need to use the temporoparietal fascial flap. And that's his final result, which is, I think, pretty reasonable considering the degree of trauma. So you can get good results using autologous tissue, and you basically never have to worry about it. Thank you.
Last talk of the session is by Bob Wallace, Microtia, Use of Alloplastic Materials. From baseball to golf.
So I want to thank Dr. Tepe for giving me the opportunity to present what's often a controversial topic to discuss. I have no disclosures. So if you look at the history of alloplastic ear reconstruction, it actually dates back a number of years. There have been a variety of substances used. Gillies and Greeley were the first. They published this in the late 30s, early 40s. Rubin was the first to use polyethylene, but it was not a porous polyethylene, and even at that early point, he realized that there needed to be some porosity in this material. Macomber, in a letter to the editor of PRS in 1960, was using a plastic mesh mold and had horrible results and came to the conclusion that that probably wasn't the thing to do. Greeley's work was interesting. He made this metal framework and was diced allogenic cartilage put in there, and the hope was that it would make a fibrous structure within this framework. But as you can imagine, the exposure rate was not so good. So some of us have seen, I'm sure, ears made of silicone, and that was first reported in 1966 by Cronin. He recognized in his early series, though, that there was a need for, again, tissue ingrowth, because silicone is not a porous material that it encapsulates. It doesn't give you porous ingrowth. So he added Dacron mesh to the outside of the implant 2 years later, and subsequently talked about free fascial grafts or temporoparietal fascial flap to try to make this work. This is a photo from his first article, and you can see this framework was rather cumbersome, and this is the early result, which would be acceptable. I think all would be happy with that, but it was the long-term outcome. Long-term being not really long-term, even a couple of years. So at the same time that came out, Amora in 1978 took the silicone and the Dacron work and started doing a large group of ears in Japan. And he had minor grade microtia results in his department and major grade microtia results in his department that really were quite impressive. But the problem was his technique. There wasn't anybody else that seemed to be able to duplicate what he was doing. He finally published a more long-term result in '84 that, again, had numbers that were not reproducible by anybody else. And at the same time in Japan, Matsunaga was also working on a silicone rubber framework. So over the course of 50-some years, you see there was continued work with silicone silastic materials as a framework for ear reconstruction. And here's a picture of Amuro's first paper, and you can see he encompassed wrapping this entirely in Dacron, the Dacron giving him ingrowth to try to prevent problems of exposure and loss of material. As opposed to Crummins' original Dacron work, they had it partially wrapped. What's really interesting is that this is recent papers. There are still people working on trying to make silicone work. There's a paper published in 2011 using phosphochlorine as adding on to the coating to the silastic framework in an effort to get ingrowth into the implant. And another paper in 2015 using 3D laser rapid prototyping for a framework. Now I'm going to skip to porous polyethylene because I think if you're going to do alloplastic ear reconstruction, this is the material to be using. So the first studies go back in the early 80s when analyzing porous polyethylene, and Berghaus did a study comparing Teflon, Dacron, porous polyethylene, looking at tissue ingrowth and rejection. And at the same time, in Europe, there's a first outcome study was published in 2010 by Braun, and it looked at the German and an Austrian experience, which had 65 patients, and 95% of the patients' parents were happy and would have the same operation again. There's a series of papers by an ENT group in New York, Tom Romo, Anthony Scalini, that looked at porous polyethylene and actually wrote a technique paper. And this came out in 2000. They modified their technique in 2006. And were the first really to talk about the hearing issue that goes along with microtia and attempting to do it at the same time. They presented Baha implantation with their reconstruction. I'll get to more the hearing in a little bit. So you can't really talk about porous polyethylene and not focus on John Reinich's paper. John, in 2009, with his fellow Sherwin, published 786 years of porous polyethylene. It was really the first large series and something that wasn't 10 or 12 patients that you really could hang your hat on an experience with his technique. His technique altered as he developed this. He started doing my ear reconstruction with porous polyethylene in the early 90s. And at the time, he was using more post-auricular based flaps, and subsequently went to temporoparietal fascial flaps. And there's some landmark papers that if you're going to do this, you've got to see the papers he wrote in 2015 and his technique paper in 2018. But the 2015 paper really looked at even a larger series of patients, and one thing's perfectly clear when you look at the data. The problems with alloplastic ear reconstruction using porous polyethylene center around two areas. One is exposure, and the second being implant fracture. So, his technique modifications had allowed that implant fracture rate to drop tremendously, and also the implant exposure rate dropped tremendously in his later cases. That stems from some modifications in the technique that was first described, including wrapping the entire implant with temporoparietal fascia. And also the implant fracturing was addressed by the ability to weld the rim piece. It comes in two pieces. You get a base block that shapes the base of the ear and a rim that makes the helical rim. and the ability to mold those into one, because the fracture parts occur at the weak spots where they're not molded. So you can see the difference in implant design. The second key component in this operation is flap, and we're talking a large flap. You can harvest it very easily through, John does this now through an incredibly small incision. I would not recommend you do this if you're starting out, but the flap is the key, because you look at this flap up here and you say, well, that's not so terribly bad, but that is exactly the problem, because that is the distal part of the flap, and that's going to cover this distal part of the implant, and that's a problem. So just take it out. Cheryl Lewin also published 3 years ago, I think, a complication paper, Management of Complications with Porous Polyethylene Microtia Reconstruction. And that's another paper that you should look at if you're going to do this. So my own personal journey with this started in 1994 at Naval Hospital, San Diego. I had used porous polyethylene for other reasons. Tad Wellish at the time was John's partner at USC, and Tad had published using porous polyethylene for burn ear reconstruction. And he and I talked, and so we did some of the very first porous polyethylene microtia reconstruction. Some of you, we made a training video for that time for it, Surgical, some of you may have seen it. But again, things that I have learned over the years, the flap is the issue. The flap has to be perfect, and the implant can't fracture. So my current practice now, when I talk to patients, is I offer them both options. I do use Supor implants, and I'll explain to you why that in a minute. And I let the patients hear the pros and the cons of each as best that I can provide them, and let them make the choice. So here's some just representative cases. This is one of the early childs. This child actually went on to play Division I college football. Standard technique. I don't do this through as large an incision anymore. And you can see in a one-stage operation, you get a pretty quick, good result early. And I think one of the benefits of this procedure versus the complaints against autogenous ribs is that you can get projection, that elevation, which is so hard with cartilage framework, is not hard with this because of the way you do it. It's just an excellent operation for a trauma here. It's so simple. You just need the helical rim. This is a child from St. Jude with melanoma of the ear. Had a resection, one procedure done. Here's a traumatic ear, one procedure, small TP fascia flap and the rim flap done. Here's my most recent case, another melanoma case. And here he is, recently 6 months post-op. There are currently 3 manufacturers that make porous polyethylene. I think everybody says it's a Medcore ear, but actually Medcore is a trade name. It's really Stryker is the owner now. It was originally procured by Porix Surgical. Stryker bought them out. And at the time, they didn't take some of the people with them to Stryker, and they started their own companies. One of them being Aaron Noble, who was an engineer, and had already been working on a more supple, more pliable, bendable porous polyethylene product, and that's what I call Supor, what he calls that. And I like that product better, and that's why I use it now. So I often get questioned, why do you do this? Why don't you do a rib? When I was at the time a consultant for Porix Surgical, and I took calls from surgeons all over the world about problems they had using porous polyethylene implants. And almost uniformly, the problems that I heard were, I think implants can let surgeons of lesser skill attempt to do things that they might not attempt to do themselves. And also, sometimes you would think it's simplistic. If you're going to do something you hadn't done, you would learn how to do it properly. And I would routinely hear people that hadn't even read the package insert about the material. So I think it's a viable option. And if you consider it, you want to learn how to do it, there's plenty of training out there. Thank you.
Okay, open for questions for this last part. If there's anybody out there that's question. Arun? Press down on the thing and continue to hold it while you talk.
Okay, thank you. For Bruce, do you ever see recurrence in your otoplasties, and if so, how do you handle it? I found, particularly when the cartilage is really soft, over time I sometimes get upper pole recurrence, and could you comment on that?
I think that occasionally we'll see a little drift to the upper pole in just a prominent ear correction. I've never had a situation we couldn't fix that under local in the office. I think with the other upper pole deformities, if you properly, splint and shape the cartilage and get the skin envelope correct, there's not much of a chance of having a problem. But occasionally at the junction points of the cartilage graft and the rim, which is so delicate, you may have to do a little trimming. With some of the constricted, more typical constricted ears, it may be necessary to